We'll start the session, and today's topic is about management of asthma. What is asthma? Okay, it is a heterogeneous disease characterized by symptoms of recurrent wheeze, cough, shortness of breath, chest tightness. The main thing here is the symptoms vary over time and intensity. So they will not be constant at any given time. So they will keep changing. That's the main crux in asthma, the variability of intensity over time. So that's the main characteristics of asthma. And the airway shows chronic inflammation, hyper-responsiveness, and airflow limitation, which is reversible, recurrent, and variable. So these are these cardinal things in asthma. One is chronic inflammation. Even when child is asymptomatic, the inflammation is ongoing. That's why we should not leave this children also. And they'll have hyper-responsiveness to any triggers. And finally, leading to airflow limitation. There's a bronchoconstriction, which can be reversible, and it will be recurrent, and it will be variable. So the objective of today's topic is how to diagnose asthma, and how to rule out mimickers of asthma, and how to assess asthma, starting a pharmacotherapy, and what are the inhalation devices which are the main crux in the treatment of asthma, and finally how to manage unresponsive severe asthma. So these are the main objectives of today's and we'll start with the case scenario. So we have an 8-year-old male child brought with complaints of recurrent episodes of breathlessness triggered by viral URTI for the past 1 year, and he's needing nebulizations for relief. And also, child had history of breathlessness while playing, and child had past history of recurrent URTI and worsening symptoms during nights and winter seasons. And there's a family history of allergic rhinitis in the brother. So based on history and clinical scenario, what is your probable diagnosis and how you are going to confirm it? Recurrent episodes of breathlessness, which is triggered by a viral prodrome, and needing nebulizations, breathlessness while playing, worsening symptoms during nights and winter seasons. What is the probable diagnosis? Okay, someone told it's asthma. Okay, how you are telling it's asthma? What made you tell it's asthma?
Father had allergic rhinitis history, and
Okay.
And night symptoms are more. So
night symptoms are more. Okay.
And history of while playing, so multi-trigger different.
Okay. Usually, if we have breathlessness while playing, what do you call it as?
Exercise induced.
Okay. Any other name?
Exertional.
Yeah, it's more like exertional. You can label it as an exertional because some work you do, you can get breathlessness. So exertional breathlessness is an like most common associated with this kind of disease. Exertional breathlessness is characteristic of which disease?
Cardiac.
Exertional breathlessness mostly cardiac. So what difference is between asthma and cardiac? These children have breathlessness while playing, and even cardiac children will have exertional dyspnea. So how to differentiate? Okay, there are other symptoms, everything is there, but based on this exertional breathlessness, is there any way you can differentiate?
In cardiac,
Relieving on rest.
Okay, relieving on rest. Yes, very good point.
Relieving on nebulization, or like
You cannot get nebulization while playing, right?
sir, MDI, like if we have given after that.
That we don't know, Gada. This is the first time child is coming to you. If child is already diagnosed and confirmed as asthma, then it's easier job for you. But this child is not came to you priorly. This child is suffering and he just came to you. So you need to differentiate whether it's cardiac or it's respiratory now. One point, what we thought was absolutely correct. So the breathlessness in cardiac will get relieved when child takes rest. But once you trigger the bronchospasm here, you cannot get that relief when you're taking rest in asthma. That's valid. And one more thing is how much exertion you did to get the breathlessness. That's the most important thing. Even for a mild exertion, if you're getting symptoms that is out of proportionate to the exertion, that is most likely respiratory than cardiac.
And respiratory, there will be chest retractions.
Yeah, even cardiac will have chest retraction because of the failure. But the only thing is it is proportionate to the exertion. So if your breathlessness is proportionate to the exertion, that is mainly cardiac. But if it's disproportionate to your exertion, then it's most likely respiratory. Because the mild exertion also triggers the airflow limitation and it can move on from there. So that's the main difference. So one thing is disproportionate breathlessness to the exertion. Second thing is relief of breathlessness with rest is mainly in cardiac. So, okay, everyone is agreed with asthma. So how are you going to confirm it? How to confirm asthma?
Responsive to the bronchodilator.
Responsive to bronchodilator.
Wheezing, breathlessness, chest retraction. Wheezing.
That and all can suggest asthma. So how to confirm it?
By spirometry, if the changes is more than 20%.
What you are going to see in spirometry?
A peak PF upon force vital capacity. PF1 in 1 second upon PF ratio.
Yeah. The first thing is for diagnosis, you need to have a criteria. So it was given for GINA guidelines. I am not talking anything out of GINA guidelines. Everything is the GINA guidelines only. So you need to have history of typical variable response. Underline that point. Typical variable. If it is not variable, it is not asthma. The symptoms should be variable. And it should be more than one type of respiratory symptom like cough, breathlessness, chest tightness, wheezing. It is not only one symptom, like only persistent cough. Even persistent cough can be like a cough variant asthma, but it's a very rare variant. So you need to have multiple symptoms, more than one type of respiratory symptom. And most importantly, it should be variable over time and intensity. And it's often worse at night and waking up. And it can be triggered by exercise, water, allergens, cold air, and they will worsen during viral infections. These are the classical history of asthma. So if you have this history, then you need to confirm the variable expiratory airflow limitation by some methods. So you need to do the investigation. One of the one thing which commonly used is spirometry, where you measure FEV1 and FEC. So mostly we'll look for FEV1. So FEV1 variability we need to check. That is mainly by bronchodilator. Either you give salbutamol and see the variability in the FEV1. If FEV1 variability is more than 12% or and it is not or it is un greater than 200 ml, then you need to label them as asthma. So FEV1 variability more than 12% and there is a greater than 200 ml variability, that is asthma. In children, you don't get that much ml. So we'll go with the 12% predicted variability. So we don't measure absolute volume change, but you'll see the percentage change because in children that volume will be less. And if you don't have spirometry and child is not able to perform spirometry, at least you can do PEFR. So it is a simple machine we can do easily perform the home as well. And you'll do it over 2 weeks. And if its variability is more than 30%, then you can confirm it as an asthma. And if you don't able to do all these things also, you start the treatment and see the response. And after 4 weeks, you assess them. and there is much improvement in the FEV1. So then again, it confirms it's asthma. And positive exercise challenge test, bronchial challenge tests are there. That and all not needed. We are not doing that thing. And finally, documented expiratory airflow limitation. So for that, you need to do FEV1 by FVC. Usually in children, it is more than 0.9. If anything less than 0.9, it can tell there is an expiratory airflow limitation. So you need to confirm in investigations two things. One is expiratory airflow limitation, that is FEV1 by FVC. It's normally 0.9 in children. If anything less than 0.9, that tells that this is expiratory airflow limitation. Along with that, you need to document there is a variability, the bronchodilator. So that is most important, variability in the function. So for variability, we won't see FVC. For variability, we'll see only FEV1. So FEV1 by FVC less than 0.9 in children, and FEV1 variability is more than 12%, then it confirms asthma. So classical symptoms, documentation of expiratory airflow limitation, that is by FEV1 by FVC, and documentation of excessive variability in lung function, that is mainly FEV1 variability of more than 12%. So you take whatever method you want, whether it's spirometry, PFR, exercise challenge test. So, but mainly thing your document is FEV1 variability. Is it clear how to confirm diagnosis of asthma? Any doubts? There are a lot of advances in spirometry than classical spirometry, which cannot be performed by younger children. Now there's a impedance oscillometry, everything is there available, so which can be easily performed even 3 to 4 years children. So with the advancement in the machines, and the younger age group also can easily perform the spirometry. So there is no problem now in confirming asthma. The main question here is, do you need spirometry to confirm asthma? Okay, this is the guidelines, it's fine. We'll talk practically, because for last 3-4 years, I did only 5 to 6 spirometers. That's all where I got it out. And I have managed more than 100 asthma children. I never feel that spirometry is very essential in diagnosing asthma. Once I rule out asthma mimics, and I know when I am giving treatment, the child is responding, it confirms asthma. No other problem will respond to the treatment you're going to give. Because you're going to give treatment for asthma, only if it's asthma, it will respond. The child is not responding, then you need to think of alternate diagnosis. So spirometry will aid you, but it's not the like very much important in diagnosing asthma. That's what I felt, and I will not usually subject the children for spirometry usually. So next scenario, what you're going to do is, it's a 3-year-old child who got with complaints of 4th episode of viral triggered wheeze in the last 1 year. In between episodes, child had few aorta episodes, and child had history of atopic eczema as well, and there's a family history of allergic to the father. So with this background, can we call it as asthma now?
Yes.
Okay. How sure you want to tell?
Not now, sir, before 5 years of age. But we can say this child is probably a child with asthmatic, because there is a family history and there is a history of atopic eczema in this child, sir.
Okay. So because of that, you are labeling this as problem. So many guidelines, many things tell that less than 5 years, labeling them as asthma, it's not correct that much. And it's like even the GINA guidance, they not make sure that how to differentiate this. So what they given is like this. So only after 5 years, you can confirm them, like you can label them as asthma. And so less than 5 years, you need to document them in 3 groups. So low probability of asthma, intermediate probability of asthma, high probability. That is what even in GINA guidance they mentioned. So they're not told it's like a confirmed asthma. So this is taken from GINA guidelines. You can see here symptoms less than 10 days, 2 to 3 episodes per year, no symptoms between episodes. The probability of asthma is very less. But if the duration is more than 10 days and greater than 3 episodes per year and severe episodes with night worsening, and in between episodes, the child had occasional cough and wheeze, then it's intermittent probability of asthma. And if symptoms are same through more than 3 episodes, in between episodes, child had some symptoms, but this child had atopic dermatitis, allergic sensitization, food allergy, family history of asthma, then high likely they are going to have asthma. So based on this, our child comes in third category. So he has a high probability of asthma. So after 5 years, if you have this kind of symptoms, then definitely you need to label them as asthma. I think I'm clear what I'm talking. So less than 5 years, don't diagnose them as asthma, but you can label them as high probability for asthma. Like low probability, intermediate probability, and high probability. And this child, what we are discussing, is in high probability for asthma. And one more index, what you can use is modified asthma predictive index. And this is for children under 3 years of age. And you need to see whether the child had 4 wheezing exacerbation last year. At least one should be confirmed by physician. And this child must have 1 major criteria, 2 minor criteria. Again, the major criteria is same. So parallel history of asthma, atopic dermatitis in the child, and if you done skin prick testing and you demonstrated that child has sensitized for any air allergens like dust mite, dog dander, molds, pollen, etc. And minor criteria, food allergy. So food allergy comes under minor criteria, it will not come under major criteria. And wheezing unrelated to course, that is what we are discussing in between symptoms. And blood eosinophil count more than 4% of the white blood cell count. So these are the minor criteria. You need to have 2 minor criteria or 1 major criteria along with the history of 4 wheezing exacerbation in the past year. If you have all these things, the risk for asthma during school age is 76%. And if you don't have this, it's high negative index. So 95% of chance that you're not going to have asthma during school years. So it's like less sensitivity and more specificity. You can easily rule out if you don't have these symptoms, not met this criteria, you can easily tell that this child is not going to have asthma. Then you are predicting that this child can have asthma based on this index. So the previous one is this is GINA guidelines. What is that told? And this is a modified asthma predictive index. So based on this, how to manage this kind of children. So recurrent wheezing is one of the most common problem we'll face in younger children like less than 5 years. If more than 5 years, it's easier for you. You label them of asthma, start the asthma treatment based on GINA guidelines. But younger, less than 5 years, whether you need to start on asthma medications or not, how to see whether they will have asthma or not, it's very dilemma. So first you categorize them into episodic and like persistent or multi-triggered wheezes. And episodic, you look for modified asthma predictive index. If it's come positive, you have to tell that it is atopic. So atopic children having recurrent wheezing, which is episodic. So what to do now? So look for that. Tell whether the symptoms are frequent, needing hospitalization in the past year. If symptoms are very much frequent and needing hospitalization, then you need to start them on daily inhaled corticosteroids, what you do routinely for asthma. And if it's not that frequent and not needing hospitalization, you can try intermittent ICS. If they're not atopic, that means negative modified asthma predictive index, then you can try, if frequent episodes are there, you can give leukotriene antagonist like montelukast. And you can, if they have intermittent episodes, you can try azithromycin as an immunomodulator. Azithromycin is not an antibiotic here. It's going to work as an immunomodulation. So in the course of wheezing, if you start them and give for 5 days, that is enough for you. If the child had persistent or multi-triggered wheezing and you look for atopic, that is positive modified asthma predictive index, then you need to start them on daily basis. No confusion here. In non-atopic, it's up to you. Either you can start daily ICS because symptoms are persistent, or you can try montelukast. So there's no difference between daily ICS and montelukast in younger children. But the problem is whatever available formulations of inhaled corticosteroids, they're approved only for more than 2 years. If more than 2 years, my choice is inhaled corticosteroids. If less than 2 years and child is having persistent symptoms and frequent hospitalizations, So then the choice comes montelukast, and be aware of that montelukast is having neuropsychiatric side effects. So be careful when you're prescribing them, you monitor them. So ICS is not approved, even the mometasone and fluticasone is not approved for less than 2 years. That's why in younger children try to avoid ICS and go for montelukast. Is it clear? I can move on. So classify them are episodic and persistent. Episodic, atopic, start them on inhaled corticosteroids is the frequent symptoms. Non-atopic, you can try montelukast or azithromycin. Persistent symptoms, atopic, no doubt, it's daily ICS. Non-atopic, either your choice, ICS versus montelukast. So to summarize, any patient with respiratory symptoms less than 5 years, you look for atopy. Do chest X-ray to road structural abnormality. This is the most important thing. Less than 5 years, you never label them as asthma at the first go. You should not label them as asthma. You need to do extensive workup to rule out the structural abnormalities and other causes. So more than 5 years, if they're having wheezing, it's less likely to be an underlying anomaly because they should have symptoms prior to that. And the first time the child is developing wheeze after 5 years, the less possibility of congenital anomalies. So in less than 5 years, always it's better to rule out structural anomalies first before even labeling them as probable asthma. And if results are consistent with asthma, you treat for that. And if it's not, you look for alternate diagnosis. And 6 to 11 years children test for atopy. Spirometry is essential here. In less than 5 years, you are not doing spirometry. It's not given in the guidelines also. And you can do FeNO measurement, but it's not needed. If you have spirometry, you can easily perform it. Even if you don't have that, you just consider possibility of asthma, start treating it. And if you got the response, continue the same and modify it according to the GINA guidelines. And if you not got the response, then you need to rule out other alternative diagnosis. So this is a summary how to diagnose asthma. And the next topic is what are the DDs or mimics of asthma? What are the things you need to consider when the child have these persistent respiratory symptoms, persistent or intermittent respiratory symptoms? Come on, we have to move on.
Foreign body.
Very good.
Cystic fibrosis.
Yes.
Primary ciliary dystonia.
Yes.
Laryngomalacia.
Yes.
On this or
Foreign body.
Yeah, foreign body.
Laryngeal wave.
First episode of bronchiolitis.
First episode of
Bronchiolitis.
so someone told cardiac wheeze, very nice. Very, very important one to rule out. Cardiac wheeze.
GRD.
GRD.
GI.
Nice. So always classify. That is what I can tell. So if you start answering randomly, you'll forget many. So my suggestion for everyone, when you're talking about causes, complications, any other deed is try to classify them so that you won't forget. So this is what I classified. I not classified, I borrowed it. And this is a common things like what you told in respiratory. It's recurrent respiratory tract infections. The cause could be anything. Another thing is the commonest mimicker is upper airway cough syndrome, which is nothing but allergic rhinitis with postnatal drip. That's the commonest mimic of asthma. Many times the child was on inhaled corticosteroids, and even they don't have asthma because they're having persistent cough in the night. It's because they lie down, the postnatal drip will cause irritation of the throat, and they'll develop cough. So your inhaled corticosteroids will not going to work for upper airway cough syndrome. So you need to modify your treatment for allergic rhinitis. So just remember this: upper airway cough syndrome is the commonest mimicker of asthma, because allergic rhinitis is that common now. Even the history will be like that: allergic rhinitis in the family, atopic dermatitis. Then you'll be easily confused with asthma. They can progress. Atopic march will be there from allergic skin eczema, allergic rhinitis, then asthma. But even before they develop asthma, they'll be on inhaled corticosteroids. That's the main problem here, and they will not respond to it, and we'll be thinking of other diagnosis. So, like you told, laryngotracheomalacia, foreign body aspiration, GERD is common. Infections, tuberculosis. Any child with recurrent or persistent symptoms, you need to rule out TB in India. Another entity is protracted bacterial bronchitis in the older children, and commonly immunodeficiencies. So recurrent RTIs, you need to think of immunodeficiencies. And congenital anomalies like airway anomalies, like bronchomalacia, congenital heart diseases, very important to rule out, and vascular anomalies. And rarely, like cystic fibrosis, primary ciliary dyskinesia, chronic lung disease, like ILD, and hypersensitive pneumonitis, like tropical pulmonary stenosis, someone suggested, like this and all can mimic the asthma. The symptoms will be very same, but we'll need to rule out. How to rule out? We'll this in the next slide. So one thing is onset in early infancy. Always rule out congenital conditions. Never label them as asthma unless you rule out all these things. Early infancy, always try to rule out congenital anomalies. And unilateral wheeze. This is the one thing which points towards a localized pathology. It could be foreign body, or it could be a congenital vascular ring, which is compressing the bronchus. And if a child had having recurrent infections, then you need to think of other diagnoses. And rare diseases like cystic fibrosis and PCOD you need to know. So this is what DDs and mimics of asthma. And what are the clinical features where alternative diagnosis or alternative conditions are more likely? Can you label them? Like I given the hint already. So we have discussed what are DDs already. So you need to tell the clinical features now. If they are there, you need to think of other causes. You should not think of asthma. That's what I'm asking.
Strider.
Excellent.
And
Failure to thrive.
Early
Someone
age.
answered failure to thrive. Excellent.
failure.
So failure to thrive in an asthma is very rare. So always remember this point. You are dealing with something else.
Unilateral or localized wheeze.
Yes. Cyanosis. Agreed.
Multi-system
Stuffing.
involvement.
Agreed. Other system involvement. Excellent. Other system involvement. Choking after food. Okay. Lovely. Already told.
Unresponsive to standard treatment of asthma.
Excellent. Non-responsive bronchial treatment. TB contact history. Nice. Recurrent infections, other sites. Excellent. Signs of cardiac failure. Yes.
Cough at early at sleeping time. Postnasal drip.
Onset of wheezing in neonatal period. It is not asthma. Wheezing in infants below 6 months, very less likely to be asthma. So you need to rule out other causes. What are the most common cause in wheezing in neonatal period?
Laryngomalacia.
Laryngomalacia will cause stridor, it will not cause wheezing.
And bronchiolitis.
No.
Neonatal. Okay, neonatal period. Vascular.
Cardiac.
Like vascular thing and possible, but most likely they'll primary ciliary dyskinesia can have this kind of picture in units in infants. The pooling of secretions and structural anomalies like bronchomalacia and non-variable fixed or persistent signs and symptoms like unilateral wheeze. That's what we discussed. And unilateral signs and wet cough, productive cough, and presence of high fevers. So this points towards
Infective.
Infective, yes. If they have this kind of recurrent episodes, what you need to rule out? Wet productive cough with high fevers, recurrent episode.
Immune,
Tuberculosis.
congenital immune deficiency.
Tuberculosis. Yeah, one thing is primary deficiency. Other thing, they can have clubbing also. They can have clubbing also.
Catagener syndrome.
Bronchiectasis.
Bronchiectasis. Any child with productive cough, you need to think of bronchiectasis. Failure to thrive, steatorrhea and clubbing.
Cystic fibrosis.
Cystic fibrosis.
Cystic fibrosis. Multiple system involvement, persistent hypoxia. You need to think of other things. Even cystic fibrosis and like confusion disorders can also possible. Poor response to bronchodilators. Wheezing with dependent edema and cardiac murmurs, heart disease. Wheezing accompanied with stridor, you need to look out for obstruction. Poor weight gain, chronic diarrhea, draining ears and sinusitis. What you're dealing about?
Catageners.
Diarrhea.
Cystic fibrosis.
Draining ears, sinusitis.
Primary deficiency.
Primary immunodeficiency.
Because you are having infections everywhere. So with this, we finished diagnosis of asthma, mimickers of asthma, and when to think of other diagnosis other than asthma. Now we'll move on to the assessment. So what all things you're going to assess when a child, okay, you label it this child as asthma, you want to start treatment. So what are you going to assess?
Severity.
What is the severity? Excellent. Next. It's common for any disease. When you want to start some treatment, you need to know. Yeah, night symptoms, everything includes severity. You need to assess severity of asthma. Then
Triggers for asthma.
yeah, triggers. You need to think about triggers and any risk factors which can worsen asthma. The first thing is you need to assess the symptom control and futurism adverse outcomes. We'll take last 1 week, 1 month duration, and we'll see how many exacerbations, how are the symptoms, night awakenings, how many times you used salbutamol inhaler, that kind of things. And second thing is assess the treatment issues. How is the technique? It's the most important thing for the failure of your therapy. What is the current step? How is the other ends? Is there any side effects for your treatment? And you need to assess the multimorbidity. So allergic rhinitis, that's a one important parameter which is commonly coexistent with asthma, which will not allow the symptom control. Unless you control allergic rhinitis symptoms, your asthma will not be under control. So always when you are diagnosing of asthma, always look for allergic rhinitis. And I see that 80 to 90% of children with asthma already had allergic rhinitis, but we are missing them. That's all. So asthma can associate with GER. So they are common as a GER can cause asthma like symptoms, and even asthmatic children, they have high proportion to have GER. Obesity, obstructive sleep apnea, and other symptoms. So they can have like their risk factors for not getting much response with the treatment. These are things going on. What is the goal of therapy? So what is your aim? Why you want to treat these children?
No exacerbation.
No exacerbation. Yes, correct.
Decrease the frequency of the episodes and control changes.
Okay. Not affecting daily activities, providing them normal lifestyle. So our main aim is two things. What is reducing impairment? So you need to prevent the chronic and troublesome symptom first. So they can do the daily activities, almost maintain near normal function. So you should not limit the daily activities like going school, doing exercises, and reducing the risk for exacerbations, and preventing the progressive loss of lung function. Even without symptoms, they can have loss of lung function. So that is the most important thing you need to address. Don't think that asymptomatic children will not have inflammation. Asthma is a chronic inflammation. Even with or without symptoms, the ongoing inflammation will be there. So you need to be very careful and provide optimal pharmacotherapy with minimal or no adverse effects. The main goal of our therapy. So one is reducing the impairments, allowing the child to have daily activities, normal activities, and reducing the risk for exacerbation, loss of lung function. These are the most important goals for our therapy. So how we are going to do that? So it involves three major areas. One thing is identification will be exacerbating factors. That's the most important thing. And you need to start pharmacotherapy, which will be stepwise. And you need to educate the parents and patients about the nature of disease and steps required to avoid exacerbation. So we'll do the first thing, identification, elimination many times, and pharmacotherapy 100% of times. But what we are not going to do is educating the parents and patients. So that is the most important thing. Then starting pharmacotherapy for asthma. If you don't educate them properly, they don't use the pharmacotherapy and they don't avoid exacerbating factors, they land up in blood. So always spend time on educating parents. It's not about the technique of inhaled corticosteroids. It's about what is the nature of the disease and how to follow. Many times they think the child is not improving or child is having recurrent symptoms again and again other treatment, and they'll be doing doctor shopping. They not use medication that properly, and child will end up in the ER with exacerbations. So that we can avoid simply by just counseling them and telling them this is asthma and it will be a lifelong disease. It's not going to improve. Are you going to have get a cure for this? And you need to be under follow up. And sometimes child will be better, not needing medications, and sometimes child needs medications, and the medications will be given for like a 3 to 6 months intervals, and we need to modify the dose and depending on the child symptom. So this is what you need to explain them and to tell them when child can have exacerbations, what the things they have to do, when they have to return to the hospital immediately. So once you explain them things clearly and they understand about the disease, and the risk of exacerbations will be very less. So that is what everyone has to practice when you are dealing with an asthma case. So what are the exacerbating factors? Exacerbating factors for asthma. Cold, exercise, yes.
Infection.
It's infections, yes. So viral respiratory infections, exercise, weather changes, air pollution, smoke exposure, pets, odors, emotions, drugs like NSAIDs and beta blockers, DER, cold air and cold food, and burning biomass, mainly air pollution. So these are the exacerbating factors. And risk factors like using more of SABA use, poor adherence to ICS technique, comorbidities, exposures, and lung function is worse at the starting itself, and higher blood eosinophil count, and having an exacerbation in the last 1 year is main risk factor for exacerbations. You can read it in the GINA guidelines. And what are the medications for long-term asthma treatment? How can you classify them?
Short
How to
acting
classify
inhaled.
medication?
Relievers, controllers.
Relievers, controllers. Okay.
Short
Can you
acting
better-
and long acting inhaled bronchodilators, inhaled
Okay.
corticosteroids,
Yes.
leukotriene inhibitors,
Yes.
and anti-allergic.
This is what I classify them. So the first type is the bronchodilators, which we are talking about relievers. Second category is anti-inflammatory. So what you're talking about is controllers. And some can act as mixed. In relievers, there are two types, beta-2 agonists and antimuscarinic agents. In both of them, you need to classify them as short-acting and long-acting. And these are the examples of short-acting, long-acting, beta-2 agonists and antimuscarinics. In anti-inflammatory, the main thing is steroids. Either you can do them systemic or inhalational. Inhalation is the best route of choice. And leukotriene inhibitors, mast cell stabilizers, monoclonal antibodies, omalizumab. So these are the other anti-inflammatory medications. And mixed, they can have bronchodilator action and other anti-inflammatory action. These are methylxanthines like theophylline, aminophylline. So this is what I classify medications for long-term treatment of asthma. So bronchodilators, anti-inflammatories. So reliever is a quick relief therapy when you need to get the symptom relief rapidly during an asthma attack. And you have short-acting beta agonists and antimuscarinic, and you have systemic corticosteroids. And also you have intravenous xanthines like aminophylline. Control and maintenance therapy is mainly to reduce the amount of inflammation and prevent the asthma attacks. This is the main role of control and maintenance therapy. Among them, you have inhaled corticosteroids, along with that LABA, long-acting beta agonists, and montelukast, long-acting muscarinic electrolyte tropium, oral theophylline, and finally biologics like omalizumab. So these are the control medications. Then the most important, what are the drugs available? Then how to start these drugs? It's mainly by stepwise approach that was given in the GINA guidelines. The type and amount and scheduling of medication dictated by asthma severity at the initiation of therapy, and level of asthma control for adjusting therapy. And because of asthma is a chronic inflammatory disorder of airway, persistent asthma is most effectively controlled with daily long-term control medication than intermittent therapy. That's the most important crux when you decide to start therapy. So your therapy is based on severity of the initiation, and when they come to follow up, you need to adjust the therapy based on the level of asthma control. So how to do this? It's a stepwise approach. So initially you need to assess, you need to confirm the diagnosis, look for what are the severity of symptoms, look for comorbidities, teach them inhaler technique, and tell them what are the goals of the control. Then when they come back, so you need to look for modified risk factors, go for non-pharmacological therapies like allergen avoidance, asthma medications up and down based on symptoms, and education. So once you review them, you look for symptoms, exacerbations, side effects, lung function, comorbidities, and again, how the patients are feeling. So assess, adjust, and review. This cycle has to go on. So you will frequently call them, like 1 to 2 monthly, and we'll assess again. And this is the stepwise approach given in GINA guidelines. Just look at here, the step 1, 2. If symptoms are less than 4 to 5 days a week, you just need to give only ICS formoterol when needed. And if symptoms are persistent, like most days, or waking with asthma once in a week in the night, then you need to start on daily maintenance, ICS formoterol. This is mainly for adults and adolescents. Or if you have persistent symptoms and waking once in a week and lung function is low, you need to step up the dose of ICS formoterol. And what is this low dose, medium dose, high dose? We'll see. On the later slides, we'll see. Low dose, medium dose, and these are 3 classification given for inhaled corticosteroid. And if still there is persistent symptoms, you can add long-acting muscarinic agonist, or you can use biological therapy. So this is what this is for 6 to 11 years old. So step 1 is low dose ICS whenever you take SAVA. Step 2 is start a daily dose of inhaled corticosteroid. Step 3 is you can start low dose ICS LABA, or you can exclude the medium dose of ICS without adding LABA. And based on this, you can step up medium dose, high dose, or medium dose ICS formoterol. It's like a MART therapy. ICS formoterol is a MART therapy. You can use them as reliever as well as maintenance. It's called MART therapy. It's your choice. What you want to start is your choice. And less than 5 years, you start with low dose inhaled corticosteroids. And if not improving, you double the low dose. There is no medium and high dose in younger children. Start with low dose, just to double the low dose. And if it's not improving, you need to refer to the specialist to look for other causes. And this is what I'm talking about. Low dose, medium dose, and high dose. It was given in the GINA as well. So depending on the age group, what is low dose? But it will be individual for each drug. So what we commonly use budesonide. You look for budesonide here. Budesonide low dose for adolescents is 200 to 400. Medium dose is 400 to 800. High dose is more than 800. So you are on step 2 therapy. You want to start at low dose. So how much dose you're going to start? So you want to start budesonide, and you want to start at low dose. You are at step 2 therapy. So what is the dose you're going to start?
200 microgram BD.
200 micrograms BD. Okay. Again, this depends on the symptoms. The child is having a little symptoms towards higher side, you can start it as 400 as well. If child is not that symptomatic and you just want to start the treatment, then you can start at lower side 200 as well, like 100 BD. Higher side is 200 BD. So with this, child is not able to get the symptom control. Symptoms are still persistent or it's increasing. Then you need to change to, you want to change to medium dose. So if you are on 400, the medium dose, you can directly go to either 800 straight away until you get the symptom control, or you can step up to 600, like 3 puffs BD. So depending on you. Usually I'll start with the high dose. Like if I want to be on step 2, like I'll start at 400, I'll see the response. And if child got the response, and after 1 month or 2 months of review, I will come down to 200. I'll maintain them on 200. So that is what I routinely do. Is it clear what I'm talking? So the doses are already given and they are the standard. So what is low dose, what is medium dose, what is high dose is standard. You don't need to decide what is low dose, what is medium dose, what is high dose. Just you need to decide what step of treatment you need to start based on the initial severity of symptoms. So symptoms here. So symptoms twice a month or more, but less than daily. Then you need to on step 2. Symptoms are for more days and waking up with asthma once in a week. Then you need to start at step 3. Directly you need to start step 3. You need to start at step 2 and step up again. Once you review the child back and the child is in symptoms at the level of step 2. Say you started at step 3 treatment, like medium dose ICS. After 1 month, child came to you and you assess the symptoms, and symptoms have calmed down, and the symptoms are now at step 2. You can always step down the treatment from step 3 to step 2. Or on follow-up, child is having persistent symptoms and it's almost moving towards step 4. You can step up the treatment. That's all. The starting of treatment is based on the symptoms child is having and which step the child fits to. You start the step there. On follow-up, you modify the treatment based on the symptom control. If he's able to have good symptom control and now he's not fitting to step 3 treatment, you come down. Or if symptoms not getting control and is stepping up, then you increase the treatment to step 4 treatment. So that is what you need to do when you are prescribing pharmacotherapy. So we'll go with the example here. So there is an 8-year-old male child, like the previous case scenario we discussed, and he had 2 episodes in a month of night awakenings, once in a fortnight, and he has history of breathlessness while playing, and your pulmonary function test confirmed it's asthma. So you want to start medication. So what medication you want to start now? What route you want to start now? What dose you want to start? That doses, previous doses is per day. These are for per day, not for per dose. All what they're given here is per day. So what medication? Okay, I'm going to give a chart for you. This is the asthma action plan, which I follow routinely. Just forgot about PEFR. No need to do about or think about PEF. And this is what I give. So you want to start treatment. So what is the step treatment you want to start now for this child? What step the child is in? Here, this is an 8-year-old child, so he has to fit into this chart.
Step
So
2.
recommended dose, only 2 night awakenings in a month. 2 night awakenings in a month. Where he fit? Where he fits step 2, step 3, step 4.
Step 3.
So he fits to step 2.
Two.
So what drug you want to start now?
Low dose ICS.
So you want to start them on low dose ICS. Okay,
Quick
fine.
relief.
So this is the low dose ICS. Bidonoside.
200, 400 daily budesonide.
No. See here, his age is 8 years. So 8 years, bidonoside, low dose is 100 to 200. Is it clear?
Yes, sir.
8 years, bidonoside, low dose is 100 to 200. So what dose you want to start now?
100 BD.
200 BD. 200 BD.
It is 100 BD. 200 BD is medium dose. All this for per day. I am not talking about per dose. It is daily dose. Whatever the numbers they given is daily dose. You can see here. Drug daily dose in micrograms. Whatever numbers they given is per day, not per dose. Again, I'm telling it's per day. So for this child, 8-year-old, who wants step 2 treatment, I need to start him on bidonoside MDI, 100 micrograms BD or single puff of 100 micrograms BD. Is it clear for everyone?
Yes.
So that is how you need to use this chart. So everyone agree that it is inhaled corticosteroids, not the oral corticosteroids. And this is what we need to write. So can anyone tell me how to write this chart? The child is in green zone. So you need to give daily medications. What you're going to give?
100 ml, sir. 100 microgram BD.
So
3 minutes.
bidonoside MDI, 100 micrograms BD. Okay. Anything else is there in green zone apart from that? In the down, just to be above yellow line, there is something which this child had. Just above yellow
Before
line.
exercise.
Before
exercise.
What do you want to give?
1 puff each. 100.
What you want to give before exercise? No.
Salbutamol.
Reliever medical.
Yes.
Salbutamol.
Reliever for exercise-induced symptoms. It is not maintenance therapy. It is reliever therapy. You need to give.
Salbutamol.
So you need to prescribe Astaline MDI as a 2 to 4 puffs just 5 minutes before the exercise. So that is the 2 things you need to write in green zone.
Sir, what about chromoline sodium here, sir, for exercise induced?
I don't know, sir. I am not using that, so I am not a person to guide you. But I am much comfortable with Astaline. See, it's working, so I'm not using chromoline at all.
Sir, can you use MART as a reliever in exercise?
Yes, definitely. If it's, the child is more than 12 years, definitely you can use. The MART is approved for more than 12 years. The problem in less than 12 years, it's mainly in the step 3 or step 4, not in the step 2. But I am more comfortable with individual drugs rather than combination because the parents also will be used with this, not having any confusion. But definitely for more than 12 years, you can try MART therapy. Definitely, even before exercise, you can give 1 puff. But better is always to give salbutamol rather than that thing. That's what I feel. I may be wrong, but it is my personal choice. That's what I feel. I feel many of my patients or parents have better compliance with the combination. I don't feel that the competence is very less. They know what to use, how to use. when to use. So I'm very comfortable with this combination, separate inhalers for both reliever and maintenance rather than combining them. The main problem is that when they have exacerbations, problem with the MART is you cannot give more than like the formoterol dose in the MART is 6 mcg and the maximum daily dose is 72 mcg. So you cannot go beyond 72 mcg. Like 6 and 72, it's only 12 puffs. You cannot give more than 12 puffs. So the problem is there. So if you don't cross 12 puffs, then you need to start on Asthma with the child symptoms not getting control. So that's a major disadvantage what I felt. But if they're able to get relieved with this 12 puffs, that's fine. Then MART is very much useful. And rather than having to, this mainly for low compliance people. But I feel the parents, if you educate them very well, they'll be more compliant. So there's no problem with using 2 inhalers, separate inhalers. The major disadvantage of the MART is you cannot cross formoterol dose of 72 mcg per day. 72 is the maximum, and some inhalers are 6 mcg, some inhalers are 12 mcg, and even the dosing for combination of budesonide and formoterol is different. Some have 100 mcg plus 6 mcg, some has 200 mcg plus 6 mcg. So depending on that, you need to keep using. And if you give 12 doses, then you're going to cross the daily dose of the budesonide. So this is what the problem with the combinations. Always you need to look for the maximum doses. Okay, we can discuss it separately if anyone has a doubts on that. And the second thing is yellow zone, where child is having symptoms, not very severe symptoms, but child is having symptoms, cough, wheeze, and tightness. So what you are going to give here? There is an 8-year-old child. So we'll talk about only 8-year-old child, not talking about adults or adolescents. I don't want to confuse you with MART therapy. You just feel that. I need you people to feel that. What is the first step there? Just feel that.
Reliever medication is salbutamol.
Reliever is salbutamol.
Salbutamol. How many puffs? 8-year-old child.
2 puffs BD.
6 puff.
2 puffs is very, very less dose. Yeah, at least 4, minimum 4. You need to go.
4 puffs.
So minimum 4 puffs and go.
Can repeat every 20 minutes, maximum up to 3 doses.
Yes. So if child not relieved and not returned to green zone, again you need to continue something. In that something, again you need to continue Astalin, again 4 to 6 puffs. Either you continue it 2nd hourly, 4th hourly, depending on the symptoms, and don't hesitate to start prednisolone. If the child is not getting better within 1 hour of your MDI, reliever MDI, at the earliest you need to start steroids. Don't hesitate to start oral steroids. It's the commonest mistake everyone will do. We'll wait, the child is better. Child, no. If the child is not returning to green, that means there's no symptoms. Always better to start this child on oral steroid. At least 3 days. Minimum. You start for 3 days, that's enough. You start only 1 mg per kg, no need for 2 mg per kg also. If the child had persistent symptoms, you can start 2 mg per kg and you give for more days. But if child having not much symptoms, mild symptoms, you start at least 1 mg per kg, give for just 3 days, that is enough. But never ever hesitate to start steroid. That's what I'm going to tell. If the child had severe symptoms, yes.
Severe, then how many days the prednisolone should be continued? Maximum 5 days?
Usually 5 to 7 days.
5 to 7 days.
It depends on the symptom control. That's what I'm telling. If you control symptoms in 1 day, you stop it at 4 days.
Okay.
If symptoms not controlled, it's taking 3 to 4 days time, you need to extend it for 7 days.
Okay.
It all depends on symptom control. That's all.
Okay.
So red zone, the child should reach the hospital. No need to waste time here. And even they cannot take MDS here, you need to give nebulizers. And you need to give 1 dose of oral steroid. Ask them to come to the hospital immediately. That is what you need to do. And in red zone, in quick relief medicine, you can modify it with Diolin. You need to give a combination. But I won't confuse many people here. So just continue salbutamol. If they have Diolin, they can use that. But if they don't have Diolin, don't confuse them. Just to give 2 medications. One is the pink one, which is the maintenance. Blue one, which is the reliever. Don't confuse them. Just to give aspirin, that is enough. But ideally, you need to have Deolin here when you're having severe symptoms. Any doubts in filling this asthma action plan? And every child having asthma on inhaler should have this plan. Without this plan, you should not send them home. Make a habit freely available in the net. Just type asthma action plan and you modify your own charts. This is what I modified and I chosen for me. And if you want to modify, you can have other simpler versions as well. But every child with asthma should have an action plan. Without action plan, they should not go home. That's a must.
Sir, a little confused about Duolin.
Any child with severe exacerbation, the choice is Deolin. It's a combination of bronchodilators like beta agonists as well as muscarinic antagonists.
Okay, sir. Thank you.
So inhalation devices, you have nebulizer, MDIs, and dry powder inhaler. What are the advantages of nebulizer over MDI, and what are the advantages of DPI over MDI? MDIs you all know. And okay, if you don't able to tell advantages, what are the disadvantages of MDI? Can anyone tell? Major disadvantage of MDI.
Complaints, sir. Technique of
No? Yeah, what is the problem with the technique?
when they don't use the spacer device properly.
Yeah. Without spacers, MDIs, you need to time the inhalation and MDI pressing. They can coordinate. The main side of problem with the MDI is coordination. Even adults cannot coordinate. Timing of inhalation and pressing of the MDI. The main problem is that. Try to others can mute. Please mute. The main problem here is timing, coordination. So you need to time the pressing of MDI with the timing of your inhalation. That should match. So to overcome that, you advise spacer. So to make them coordinate well, you use spacer so that the problem is over. And what are the advantages of nebulizer over MDI? So we know the disadvantage of MDI and we know how to overcome it by using a spacer. Now you tell me what are the advantages of your nebulizer?
Moist form of this one.
The main advantage of nebulizer is the patient effort is not needed. Like in severe exacerbations where the patient effort is not there, they cannot use MDIs. So except that, nebulizers has no role usually, except in regular exacerbations of asthma. Regular use of nebulizers is not advisable, and even for younger children, you use a mask, MDI spacer and mask, that is enough. I stopped using nebulizers for maintenance therapy. Nebulizers is only for relief medications during acute exacerbations. And what are the advantages of DPA? Yeah, please go on.
Can use oxygen at the exacerbation state that will be needed.
All nebulizers using beta 2 agonist should be given oxygen driven. That's the main thing. You cannot use nebulizers with beta. If you want to give bidicartho nebulization, I am fine. If you are giving beta 2 agonist like salbutamol through nebulizer in the home is not advisable.
Yes.
They can cause VQ mismatch and they can cause hypoxia. I'm not going to go for theory in that. So without oxygen, you cannot give beta 2 agonist through nebulization.
Yes.
And what is the advantage of DPI? The main advantage of DPI is it is a breath accentuated. So the coordination is very good. You don't need to worry about when to inhale. Unless you inhale, the drug will not be delivered. You don't need to time it. You just keep it in the mouth, inhale, the drug will go to the lungs. That is a major advantage of DPA. So if you ask me what is the best thing, inhalation devices, you go for breath accentuated devices, because you are not going to have problem with coordination. But the main disadvantage of MDA is overcome by using spacers. So for younger children, still MDA with spacer is the best one, because in DPS they need to use more force that cannot be generated by younger children. So older children, adolescents, if they're able to generate more force, DPA is the best. Younger children and infants, MDA with spacer plus or minus mask is best. So choice based on age. So younger children less than 5 years, 6 meter dose inhaled spacer plus or minus mask. Second choice is nebulizer, but always oxygen driven. Younger children like 6 to 8 years, against first choice is MDI, second choice is DPI. And more than 8 years, see here, the first choice is DPI. Or you can use MDA with spacer. Anything. If the child is able to generate force, DPI is fine. If it's not able to generate force, you can use MDA with spacer. Both are safe. So this is the choice based on the age. So for this child, what device you want to choose? 8-year-old child?
MDA.
DPA.
MDA with spacer. Always don't stop there. MDA with spacer. You need to never ever give MDA without spacer for any child. Even for adults, now the recommendation is to use spacer. So never hesitate to use spacer. It's a must now. So from this class, you need to learn this one point. Never ever prescribe MDA without spacer. Even if they're able to do it correctly, I will not give without spacer. And finally, we start the treatment and we need to monitor. How will monitor them?
I'll ask them to maintain a chart, sir, at home, daily notebook.
Yeah, symptom
And when
chart.
they come on.
Symptom diary, that's called asthma diary. You need to ask them to maintain asthma diary with all the symptoms, and they just have to tick that, they have to put the date, symptoms, and they have to keep ticking. Cough, yes, okay, tick. Cold is there, tick. Fever is there, tick. Wheezing is there, tick. If nothing is there, just leave it. Sneezing, tick. So these are all the things they need to monitor in the home, and they have to come back to you every 2 to 6 weeks interval, and we need to assess them how is the symptom control. And if they're under control, you can just space them the intervals. And during follow-up, you need to step up or step down based on the symptom control. And you need to step down. You need to get down to the minimal medication just to maintain the control. Very minimal medication. And you need to consider 3 monthly intervals if a step down therapy is anticipated. Once you step down, at least you need to maintain it for 3 months before you do the further step down or you further stop it. So these are the table given in JINA guidelines for assessment of symptom control. So you need to assess it over past 4 weeks, and it's about daytime symptoms, night awakenings, how many SABA used, and any activity limitation due to asthma. You need to classify them as well controlled, partly controlled, uncontrolled. If they are well controlled, you can step down. Partly controlled, what you have to do? Partly controlled, uncontrolled, what you have to do?
Check the technique, sir, whether they're doing properly or not.
Child with poor control. Yes, you need to check the technique. 100% correct. First important thing you need to do. Anything else before that?
Whether they're complying with this or not, or whether we should rule out other causes, sir.
Exactly.
Any
Whether it is
exacerbation history.
So first you need to deal with whether it's asthma or not. So if it's not asthma, it's not going to work. If you confirm it's asthma, then why it's not working? Then you need to take the inhaler technique. If inhaler technique is correct, fine. Not correct, you got to modify it. Even if inhaler technique is correct, why it is not responding? Then you need to look for triggers or risk factors. So triggers like tobacco smoke, allergens, you need to modify them. Or look for comorbidities. Comorbidities like GER, obstructive sleep apnea, these are the allergic rhinitis. So these are the things you need to look. Is it clear? First thing, is it asthma or not? Okay. It is not asthma, you treat it. You confirm it is asthma. Then check for inhaler technique. Inhaler technique is wrong. Modify it, reassess. Inhaler technique is correct. Then you need to look for risk factors or triggers. If it's not there, then look for comorbidities. So you need to go stepwise fashion when child is having poor control symptoms. Is it clear? Okay. So this child, we modified the inhaler technique. It's a wrong technique. We modified it. He has well controlled symptoms now. Child was on 200 mcg of budesonide per day. So what do you want to do now? Child came to you with well controlled symptoms, and the current dose was 200 mcg. So what do you want to do now?
We'll continue the same for the
Can-
6.
Continue same. Okay.
Can we decrease
How
the
many
dose?
days? You have to continue same. You are going to continue for lifelong?
For 6 months or 1 year, depending upon the.
No. There is no guidelines which will tell you to continue for 6 months and 1 year. The maximum duration, what they tell is 3 months. So every time you need to modify. If the symptoms are well controlled for this child, I will continue it for another 1 to 2 months. And if the symptoms are well controlled continuously, I am going to step down. I cannot stay there. The main goal for my pharmacotherapy is to reduce the doses to the minimum possible extent where symptoms are under control with least possible side effects. Is it clear? Minimal dose where symptoms are under control to get least possible side effects. That is the crux of your pharmacotherapy. So at the end of 1 or 2 months, I am going to come down to 100 mcg per day, like 1 puff OD. Still, the child is way better on this. Another 3 months, I am going to stop it. I am not going to continue it. In between, child had symptoms and exacerbations, then I am going to modify it. I am going to step up. So depending on the control, I am going to do this. If child is well controlled, at the end of 1 or 2 months, step down. Don't stay there. You need to step down to the minimal dose possible. And even on minimal dose, for 3 months, child is okay, you can stop it. Is it clear?
Yes, sir.
So the summary slide. So this is a summary slide for asthma diagnosis and management algorithm. So you need to confirm the diagnosis. Child have persistent symptoms of asthma. You need to confirm the diagnosis. You confirmed asthma, you assess the patient and start the management. Either it is non-pharmacologic or pharmacologic. Like you need to prevent the environmental exposure. You need to vaccinate them for infections. And you need to avoid the allergens. That's the prevention. And you need to educate them on regular basis about exposure, cessation of smoking and biomass, and how to use the technique. And pharmacologic treatment, you start them, what is the step of the treatment you need to decide, and you start the therapy. Then again, you ask the patient to review back, and you need to see the control. Acceptable control, just continue them and step down. Control not acceptable, you need to modify. Either you step up or add one more therapy. If the child come with acute exacerbation, treat the acute exacerbation, then you modify the treatment. Is it clear? The symptoms,
Yes.
confirm the diagnosis of asthma, Once you confirm, assess the patient, start on the treatment. During treatment, you need to have 3 prongs. One is pharmacologic. Second thing is prevention, like exposure to allergens, modifiable risk factors. And most important thing is education. Unless you educate the parents, your success in treatment is not going to be there. Then you review the control and follow up. Either you ask them to come back at 4 weeks or 6 weeks. If control is there, you just step down and continue it there, and you can stop it there. Or if not controllable, you need to look for the 3 things: step 1, step 2, step 3. How do you discuss it? Then you modify them. If child come with acute exacerbation, you need to treat it, and then you modify your treatment. Is this okay? Thank you.